Sriyadaita Padaghara Srivashadi Gaur Bhakta Vrinda Hare Krishna. Person regarding the weather also. Okay, okay.
I am doing just I will finish.
You are in prayer? Yes, yes,
Yeah,
yes.
I
Please complete. Please complete. I will. Okay. Given the following lab results, decrease decrease hemoglobin and decrease fibrin and degradation product. So what is the diagnosis? Diagnosis is disseminated endovascular coagulation. Disseminated endovascular coagulation. Okay. Now, what is the diagnosis? What is measurable blood transfusion? Replacement of one blood one blood volume in 24 hours or more than 20 more than 10 units in 24 hours, or replacement of 50% of blood volume in 4 hours, or more than 4 units in more than 4 units in 1 hour is called massive blood transfusion. And ratio or the protocol is fresh frozen plasma platelet, fresh frozen plasma platelet, fresh frozen plasma platelet 1:1:1. When do you start to give plasma or and platelet to with the whole blood? In case of ongoing coagulopathy, in case of ongoing coagulopathy with continued in case of ongoing coagulopathy with continued bleeding, in case of ongoing coagulopathy with continued bleeding, as a part of massive blood transfusion protocol, in case of ongoing coagulopathy, in case of ongoing coagulopathy, in case of ongoing coagulopathy with the continued bleeding as part of massive transfusion protocol, and DIC. What is the cause of ascites in this patient? Okay, hypoalbuminia increase in expecting his reply. Okay. Hypoalbuminia, hypoalbuminia increase the formation of hypoalbuminia and increase the formation of hepatic and strengthening lymph, and retention of the salt and water due to activation of the aldosterone, retention of the salt and water due to increased aldosterone, and antidiuretic hormone level. Retention of the salt and water due to retention of the salt and water due to increased aldosterone, and antidiuretic hormone level. Blood finding in a patient abusing alcohol. Are you there? Okay. Blood finding patient abusing alcohol. Okay. Low platelet due to toxic effect of low platelet due to toxic effect of the bone marrow. Raised mean corpuscular volume (MCV), and megaloblastic anemia, elevated enzyme like GGT, ALT, AST, and ferritin. Okay, so blood picture of a alcoholic patient. What will happen? They have low platelet due to toxic effect on the bone marrow, raised liver enzyme GGT, ALT, AST, and ferritin, megaloblastic anemia, and raised MCB. MCB raised but platelet low. Mhm. And megaloblastic anemia with elevated liver enzyme. This is alcoholic. Causes of thrombocytopenia in this case. Esra, are you there? Hello. Causes of thrombocytopenia in this case, hyperesprenism, DIC, chronic low platelet, hyperesprenism, thrombocytopenia, hyperesprenism, DIC, chronic low platelet production, and hemodilation. Causes of thrombocytopenia. Why platelet is low? Because of dilution and hyperesprenism. More are platelet breakdown. DIC, chronic low platelet production, and hemodilation. What is the indication of platelet transfusion in case of ongoing coagulopathy with the continued bleeding as part of the massive blood transfusion protocol? After discussing with the hematologist and DIC, explain portal hypertension in alcoholic patient. Explain portal hypertension in alcoholic patient. Explain portal hypertension in alcoholic patient. Okay. Mm, Explain portal hypertension in alcoholic patient. Explain portal hypertension explain portal hypertension in alcoholic patient. Portal hypertension in liver cirrhosis. Liver cirrhosis because of the chronic liver disease. This patient is alcoholic. So there will be liver cirrhosis, which is the liver cell damage, damage of the hepatocyte, and there will be fibrosis and nodular degeneration. Liver cell damage, fibrosis, and nodular degeneration. The fibrosis obstructs portal venous return. Fibrosis obstructs portal venous return, and will increase the portal venous resistance. Fibrosis obstructs portal venous return. You came back. Hmm. Okay, so we are starting from here. Blood picture in alcoholic patient, low platelet due to toxic bone marrow effect, raised mean corpuscular volume, megaloblastic anemia, elevated liver enzyme, ALT, AST, GGT, and ferritin. Causes of thrombocytopenia in this case, low platelet production due to toxic bone marrow effect and hypersplenism, and DIC, also hemodilation. And what is the indication of platelet transfusion in case of ongoing coagulopathy with continued bleeding as part of massive blood transfusion protocol after discussing with the hematologist and DIC? Explain portal hypertension in alcoholic patients. The alcoholic patient has chance of development of cirrhosis of liver, which will cause damage of the liver hepatocyte and fibrosis and nodular regeneration. This fibrosis obstruct the portal venous return, which will increase the portal vascular resistance and according to the equation, blood pressure is equal to flow by resistance. It will increase portal hypertension. Fibrosis obstructs the portal venous return, which will increase the portal vascular resistance, and with increased resistance, the portal venous return will increase. So it will cause portal hypertension. Also, if there is any artery venous shunt, artery venous shunt, artery venous, if there is any artery venous shunt within the liver, artery venous shunt within the liver also contribute to hypertension. Okay. One is cirrhosis of liver, which causes liver cell damage, fibrosis, and nodular regeneration, and the fibrosis obstruct the portal venous return, which will increase the portal vascular resistance, and blood flow against resistance increase the pressure, portal venous pressure. And if there is any artery venous shunt within the liver, it contribute to hypertension. Patient with macrocytic anemia. Patient with macrocytic anemia, what could be the cause? Nutritional deficiency. This alcoholic patient, okay, nutritional deficiency, vitamin B12 deficiency with chronic alcoholism. Nutritional deficiency, vitamin B12 deficiency with chronic alcoholism. Nutritional deficiency, vitamin B12 deficiency with chronic alcoholism. Nutritional deficiency, vitamin B12 deficiency, nutritional deficiency, vitamin B12 deficiency, nutritional deficiency, vitamin B12 deficiency with chronic alcoholism. Nutritional deficiency, vitamin B12, nutritional deficiency, vitamin B12 deficiency with chronic alcoholism. Okay. um, Protosystemic sites of protosystemic anastomosis, lower end of the esophagus, umbilicus, bare area of the liver, rectum, lower end of the esophagus and upper anal canal, lower end of the esophagus, upper anal canal, umbilicus, bare area of the liver, and patent ductus venosus, retroperitoneal. Again, lower end of the esophagus, upper anal canal, umbilicus, bare area of the liver, uh, and retroperitoneal. Caput medusa. transjugular intrahepatic protosystemic stent shunt. Tips: transjugular intrahepatic protosystemic stent shunt and staple esophageal transection. Stapled esophageal transection. The gastric vein and the short gastric veins. The gastric vein and the short gastric veins are ligated, and the distal esophagus is transected and re-anastomosed just above the cardiac using a stapling gun. Re-anastomosed just above the cardiac using a stapling gun. Okay, stapled esophageal transection and orthotopic liver transplant. So these are the options for protosystemic shunt. What they are doing, one is transjugular intrahepatic protosystemic stent shunt, esophageal, staple esophageal transection, and orthotopic liver transplant. Staple esophageal transection is staple esophageal transection and orthotopic liver transplant. Hmm. Stapled, stapled. Hmm. This is the treatment of choice in advanced liver disease. If advanced liver disease, then liver transplant. Okay. It is a it is a double balloon tamponade. It is a double balloon tamponade. What is Sangstaken tube? It is a double balloon tamponade. Okay. This is Sangstaken tube. They have double balloon. One is gastric balloon, another one is esophageal balloon. And here they have multiple port like one, two, three. One is for balloon inflation, one for gastric, one for esophagus, one for gastric, one, two for esophagus, and another one gastric aspiration. With one can take out the air or the content, and with two they can inflate these two balloons. So this is double balloon tamponade. Okay. How to mhm, yes, port for gastric balloon, port for esophageal balloon, two balloon, and one suction. Port for gastric balloon, port for esophageal balloon, and port for gastric suction. Okay. Position of the patient and elevate the head of the bed 45 degree. Anesthetize the posterior pharynx and nostril with topical anesthetic. Coat the balloons with lubricant jelly. Coat the balloons with lubricant jelly. Coat the balloons with lubricant jelly. Pass the tube from the nostril at least 50 centimeter mark. Suction from gastric and esophageal port. Suction from gastric. See, there is no esophageal port in esophagus, but here they said suction from the gastric and esophageal. If esophageal port, then that will be Minnesota tube. We'll get another question. What is Minnesota tube? Like Sangstecken Blackamoor tube, extra port for the esophageal suction. So ultimately here what is written that not for the Blackamoor tube. It is for the Minnesota tube. So if they ask about this Blackamoor tube, we'll say here suction from the gastric. If specifically we can remember, then it is okay. It is not very important, but just we can remember. Pass the tube from the nostril at least 50 centimeter mark, then suction from the gastric port, and when the gastric balloon is correctly positioned in the stomach, When the gastric balloon is correctly positioned in the stomach, inflate the balloon with 500 ml of air and clamp the port. Pull the tube back. Okay, clamp the port. Pull the tube back until resistance is felt against the diaphragm. Inflate the esophageal balloon by the sphygmomanometer to 30 to 45 millimeter mercury and clamp the port. When the bleeding controlled, reduce esophageal port by 5 millimeter every 3 hours until 25 millimeter because it is 30 to 45 millimeter. So when bleeding controls, reduce the esophageal balloon by 5 millimeter every 3 hours until 25 millimeter mercury is reached without bleeding. Then keep the tube for 12 to 24 hours. When the bleeding is controlled, reduce the esophageal balloon by 5 millimeter every 3 hours until it reached 25 millimeter mercury. And without bleeding, then keep the tube for 12 to 24 hours. Deflate the esophageal balloon for 5 minutes every 6 hourly to prevent esophageal necrosis. Okay. To control acute life-threatening bleeding from esophageal or gastric varices if that does not respond to the medical therapy, including endoscopic hemostasis and vasoconstrictor therapy. When endoscopic hemostatic or vasoconstrictor therapy are unavailable, okay. When medical treatment fail to control the esophageal or gastric varices, or when the endoscopic band ligation is not available. Okay. Like Sangsten Blackwater tube, it is a double balloon catheter with a extra esophageal suction port. If there is stricture and recent surgery, stricture and recent surgery, common, okay, stricture and recent surgery. We cannot use Sangsten Blackwater tube. Aspiration pneumonia, failure to stop bleeding, pneumonia. If left for long time, it can cause esophageal necrosis that can lead to perforation. Okay, aspiration, failure to, okay, aspiration pneumonia, failure to stop bleeding. We are reading what? Black hemorrhage tube, complication. Okay, like emerald tube we inserted, there could be aspiration pneumonia, then it failed to stop bleeding, pneumonia, and if left for long time, it can cause esophageal necrosis that can lead to perforation. Okay, if left for long time, it can lead to esophageal necrosis and followed by perforation. Mhm. You were asking this one. Next one, or what? Okay. Uh, Patient will have megaloblastic anemia, raised MCV, low platelet, and elevated liver enzyme, GGT, ALT, AST, and ferritin. Mm, Hypersplenism, DIC, and low platelet production due to toxic effect on the bone marrow. One more. hemodilution, yes. Mm. Uh, as the patient is a smoker and chronic NSAIDs user for osteoarthritis, and now have acute onset of abdominal pain and abdominal tenderness. So I will suspect it is a perforated peptic ulcer. This is the X-ray of Mr. X taken on this date, the hospital number this, and here it is showing trachea is centrally placed and mediastinum also not shifted, and bilateral pleura is clear. But I can also see the ear under the diaphragm, so it is suspected that this is a perforated hollow viscus. O- Okay, chronic NSAID user, uh, one more was chronic NSAID user and smoker in general, Helicobacter pylori infection, chronic use of NSAIDs or steroids, previous gastric surgery, advanced stage. Okay, H. pylori, malignancy. Okay, so for this patient, smoker and NSAIDs, risk factor of the perforation, NSAIDs, steroid, H. pylori, previous peptic ulcer, okay, not gastric surgery, previous peptic ulcer and malignancy. NSAIDs, steroid, H. pylori, previous peptic ulcer and malignancy. Okay, suppression of the gastric prostaglandin synthesis by inhibiting of COX-1, topical irritant effect on the epithelium, impairment of the barrier property of the mucosa, reduction of the gastric mucosal blood flow, interference with the repair of the superficial injury. Suppression of the gastric prostaglandin synthesis by inhibition of the COX-1 topical irritant effect on the gastric epithelium, impairment of the blood barrier property, impairment of the barrier property of the mucosa, reduction blood supply in the mucosa, and interference with the repair of the superficial injury. uh, CRISP protocol using ABC approach and keeping the patient NPO and PPI, and will prepare for definitive management. Keeping the patient NPO because perforation, of course, we need to keep him NPO, and the previous one where there was bleeding, ongoing bleeding. Main thing was we started IV fluid. No, instead of IV fluid, we started directly blood transfusion. And here perforation, we are keeping the patient NPO and PPI and prepare the patient for definitive management. That will be omental patch repair, good peritoneal toilet, and intra-abdominal drain. If malignancy is suspected, then we can take some biopsy. Again, omental patch repair, good peritoneal toileting, and intra-abdominal drain if perforated gastric ulcer. Hmm. Omental patch repair, good peritoneal toilet, uh, good peritoneal washout, we will say. Omental patch, good peritoneal wash, and intra-abdominal drain if perforated gastric ulcer, and take a biopsy to rule out malignancy if perforated gastric ulcer. Definitive management will be the repair of the perforation by omental patch, peritoneal toileting, and intra-abdominal drain. Also take a biopsy to rule out the malignancy. Same thing written. Okay. Okay. NCEPOD stands for the National Confidential Inquiry on Patients' Outcome and Death. National Confidential Inquiry of Patients' Outcome and Death. National Confidential Inquiry of Patients' Outcome and Death. Classification of this operation, it will be urgent. Urgent. Of this operation, perforated gastric ulcer, it is urgent. Long-term PPI and long-term PPI, antiemetics, antibiotic. Okay, we can skip. Gastric ACL, it activates the pepsin to pepsin, stimulates small intestine to release CCK and secretin, and promotes absorption of the calcium and iron in the small intestine and antimicrobial. It activates pepsin to pepsin. It gives optimal environment for the pepsin, stimulates small intestine to secrete secretin and CCK. It promotes absorption of the calcium and iron in the small intestine. It has antimicrobial effect. Hmm. Hmm. In cephalic phase, it has three phases: cephalic phase, intestinal phase, and gastric phase. Cephalic phase, gastric phase, intestinal phase. Cephalic, gastric, intestinal. In cephalic phase, 30% acid is produced by vagal cholinergic stimulation. It causes secretion of ACL and gastrin release from G cell. It causes secretion and stimulation. Vagal cholinergic stimulation causing secretion of ACL and gastrin, both causing secretion of ACL and gastrin from the G cell. Um, Usually, okay, cephalic phase by the taste or the smell of the food. 30% acid is produced by vagal cholinergic stimulation, causing secretion of ACL and gastrin release from the G cell. And gastric phase, when the food is into the stomach, 60% acid is produced. So stomach will be distended, pH will be low, and causes gastrin release. This phase also gastrin release. First phase, ACL and gastrin both release due to vagal cholinergic stimulation, and gastric phase, food in the stomach, there will be stomach dilatation, pH low hydrogen ion, and peptides causes gastrin release. Peptides causes gastrin release. Peptides causes gastrin release. Okay. ACL and gastrin release, and here peptides causes gastrin release. And intestinal phase, food in the duodenum. So food in the duodenum, 10% acid is produced. High acidity because food came directly from the stomach. High acidity, distension, and hypertonic solution in the duodenum come from the stomach. Again, high acidity, distension and hypertonic solution is in the duodenum. This inhibits gastric acid secretion. This inhibits gastric acid secretion. This inhibits gastric acid secretion via CCK and secretin. CCK and secretin. First phase ACL and gastrin. Second phase also gastrin. And third phase here CCK and secretin. Secretin and neural reflex, because food is already in the duodenum. So in the stomach, no need of acid. It will increase acidity. That is why they inhibit gastric acid secretion by CCK and secretin and neural reflex. Okay, cephalic phase 30%, gastric phase 60% by gastrin, peptide by gastrin, and intestinal phase 10%. Gastric outlet obstruction. 58-year female presented with persistent non-bilious vomiting. Now he is drowsy, hypokalemic, hypochloremia, and metabolic alkalosis with aciduria. What is the diagnosis? Gastric outlet obstruction cause, benign cause, malignant cause. Benign cause, pyloric stenosis, secondary to chronic peptic ulceration. Benign pyloric stenosis secondary to chronic peptic ulceration. Secondary to chronic pyloric stenosis secondary to chronic peptic ulceration and malignant gastric or pancreatic cancer. Okay. Why potassium is low? Hmm. Potassium is low because due to increased aldosterone in response to hypovolemia. So aldosterone causing potassium excretion and also it is shifting of potassium inside the cell. Okay, due to increased aldosterone in response to hypovolemia. Due to increased response, due to increased aldosterone, due to increased aldosterone, due to increased aldosterone in response to hypovolemia, and which will absorb sodium and water in exchange of potassium in the kidney, and loss of potassium in the vomitus. Loss of potassium in the vomitus. Okay, so potassium low because of two reasons. One is increased aldosterone because of the hypovolemia, and this aldosterone will cause salt, sodium, and water retention in exchange of potassium in the kidney. Loss of potassium in vomitus. Why chloride low? Due to loss of chloride in the form of ACl in vomitus. Alkalosis, potassium, okay. Loss of hydrogen ion in the vomitus, one reason. Then increased bicarbonate uptake in renal tubules in response to loss of chloride in order to maintain electrochemical neutrality. Loss of hydrogen ion in vomitus, increased bicarbonate uptake in renal tubules in response to loss of chloride. Both are minus ions, bicarbonate and chloride. So chloride is losing by increased bicarbonate uptake in renal tubule in response to loss of chloride in order to maintain electrochemical neutrality. Increased bicarbonate uptake in renal tubule in response to loss of chloride ion to maintain electrochemical neutrality, and retention of the bicarbonate rich pancreatic juice. Retention of the bicarbonate rich pancreatic juice. Retention of the bicarbonate rich pancreatic juice due to loss of acid load in the duodenum. Retention of the bicarbonate rich pancreatic juice because as the obstruction, the acid is not coming, stomach secretion is not coming. So what coming only from the pancreas, which is rich in bicarbonate. So retention of bicarbonate rich pancreatic food. Hmm. Retention of bicarbonate rich pancreatic juice due to loss of acid load in the duodenum. Okay. Hyponatremia. Sodium is losing because of the vomiting, and kidney excrete more sodium bicarbonate to reduce blood alkalinity. We read this one before. They want to excrete more potassium. Also, increase influx of potassium inside the cell by alkalinization of the urine. Remember, in rhabdomyolysis station, we read this one. Hyponatremia. That will cause hyponatremia. Kidney excretes more sodium bicarbonate to reduce the blood alkalinity. Hyponatremia. Kidney excrete more sodium bicarbonate to reduce blood alkalinity, and there we added this sodium bicarbonate. And here we are saying we are losing bicarbonate to reduce the blood alkalinity, and there we need to gain alkalinity to prevent further damage because of acidosis. And here, kidney excretes more sodium bicarbonate to reduce blood alkalinity and sodium loss in the vomitus. Okay. Is sodium bicarbonate excreted as a whole? Yes. Why aciduria? Because of hydrogen ion excretion with urine in exchange of sodium. Why aciduria? Because of hydrogen ion excretion with urine in exchange of sodium. Hyponatremia classification according to okay. Hyponatremia according to serum osmolarity. According to serum osmolarity can be divided to isotonic, hypotonic, and hypertonic. Isotonic, hypotonic, and hypertonic. Hypotonic, and hypertonic. Hypotonic hyponatremia again divided according to the volume. Hypovolemic hyponatremia, uh, like diarrhea, vomiting, DVD, diarrhea, vomiting, diuretics. Hypovolemic hyponatremia, diarrhea, vomiting, dehydration, or diarrhea, vomiting, diuretics, and euvolemic hyponatremia, SIADA, SIADH, and hypothyroidism. SIADA, SIADH, and hypothyroidism, and hypervolemic hyponatremia. Hypervolemic hyponatremia due to heart failure, liver disease. Hypervolemic hyponatremia, heart failure, liver disease, and pseudohyponatremia, multiple myeloma. Hypovolemic hyponatremia, diarrhea, vomiting, and diuretics. Euvolemic hyponatremia, SIADH, hypothyroidism, SIADH, and hypothyroidism, and uh, hypo hypervolemic hyponatremia, heart failure, liver disease. Pseudohyponatremia, multiple myeloma. Complication of hyponatremia in the brain can cause cerebral edema, seizure, and decrease consciousness level, confusion. Can cause cerebral edema, seizure, decrease consciousness level, and confusion in the heart, MI, heart failure, in the chest, shortness of breath, chest pain. In the chest, shortness of breath, chest pain. In the liver, hepatic encephalopathy. In the kidney, can cause renal failure. How to correct the condition of the patient? Patient is a critical. This patient is a critically ill patient. So I will start managing this patient according to this protocol using ABCDE approach, and I will call for help of the HDO registrar and keep the patient NPO, insert two white bore cannula, and send blood sample. I will start fluid resuscitation by sodium chloride and potassium chloride supplementation. Then I will go for definitive treatment, endoscopic, gastric dilatation, and pyloruplasty, because there is pyloric obstruction or narrowing. So, definitive treatment will be endoscopic gastric dilatation, okay, endoscopic gastric dilatation, and pyloruplasty. Endoscopic gastric dilatation and pyloruplasty. You said how pyloruplasty is done. Uh-huh. Living, sleep. In the morning, you slept very nicely. Who will you involve? Definitive treatment, endoscopic gastric dilatation, and pyloruplasty. Endoscopic gastric dilatation and pyloruplasty. Endoscopic gastric dilatation and pyloruplasty. Endoscopic gastric dilatation and pyloruplasty. Also, partial gastrectomy. Another option is partial gastrectomy with jejunostomy with vagotomy. Partial gastrectomy with jejunostomy with vagotomy. Okay, we'll see this one in that answer. Who to involve? Gastroenterologist, general surgeon, I2 specialist, and cardiologist, and anesthetist. Gastroenterologist, general surgeon, I2 specialist, cardiologist, and anesthetist. When will this patient be fit for surgery after correction of the electrolyte disturbance and patient is stabilized? Chloride shift of the chloride into the intracellular compartment of the RBC in exchange of bicarbonate ion. Shift of chloride ion into the intracellular compartment of the RBC in exchange of the bicarbonate ion. What is the single bedside test you will do? A, B, G. What is the clinical picture of gastric outlet obstruction? Dehydration. So many picture in the file. See this picture. Okay. Mm. Clinical picture of dehydration, dehydration, non-bilious vomiting, dehydration, non-bilious vomiting, left hypochondrial fullness, dehydration because of the vomiting, non-bilious, yes, dehydration, non-bilious vomiting, left hypochondriac fullness, left hypochondriac fullness, and visible peristalsis. Okay, visible peristalsis. First, dehydration, 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 non-bilious vomiting, dehydration, non-bilious vomiting, left hydrochondrial fullness, and visible peristalsis. Left hydrochondrial fullness, and visible peristalsis. Dehydration, left hydrochondrial fullness. Hmm. Yeah, non-bilious vomiting means directly the content from the stomach. I will give all this file to you. You can. Hmm? Yes, I will give you everything. Yes, again. Yes, again I will give because there is a small modification, addition, correction. You no need to print now. You can print later. So it is obstructed jaundice. It is obstructed or post-hepatic jaundice. Bilirubin circulate as the free bilirubin conjugated to glucuronic acid and bound to albumin. Free bilirubin conjugated to glucuronic acid and bound to albumin. Urobilinogen is a colorless byproduct of the bilirubin metabolism formed by deconjugation of the bilirubin by gut flora. It is a colorless byproduct of the bilirubin metabolism, which is formed by deconjugation of the bilirubin by gut flora. Some are excreted in the feces. Okay, directly they started from there means in large gut. They started the description from the large gut, even large gut after deconjugation. Okay, okay, okay. One second. Urobilinogen is a colorless byproduct of the bilirubin mechanism deconjugated by bilirubin, deconjugated by gut flora, then some are excreted in the feces after oxidation and forms the stercobilin. So I can follow this chart. It is easy. Urobilinogen after oxidation, some are oxidized by gut flora and passes with the stool, and some are reabsorbed and enter into systemic circulation. And from the reabsorbed, some part enter into the systemic circulation, and some are enter into the renal system and excrete with the urine. Some of the reabsorbed urobilinogen is again excreted by the liver, but small amount enter the systemic circulation and excreted in urine. It is absent in urine because of the obstruction of the flow of the bile, and the bilirubin does not reach the gut. Hmm, hmm. Because of the obstruction in the flow, they don't reach in the gut. Okay. Bile salt help in fat digestion and absorption. By emulsification of fat into micelle, thus it provides increase the surface area of the action for enzyme pancreatic lipase. It is important for fat digestion and absorption. How they do this? By emulsification of fat into micelle, thus provides the increased surface area of the pancreatic lipase enzyme. Increase the surface area for the action of pancreatic lipase enzyme. Okay. Bile salt has hydrophilic and hydrophobic portion. They aggregate around the lipid droplet to form the micelle. They aggregate around the lipid droplet to form micelle, with the hydrophobic side towards the fat and hydrophilic side facing outwards. The hydrophilic side are negatively charged, and this charge prevent fat droplets to re-aggregate into large fat particles. Hmm. What he replied? Wait, wait, wait. They are asking 2000 for pickup. Oh my god. 2000. This is high. And he said cooking facilities is there. There is kitchen. I can cook there. So I will carry my rice cooker. And they said there is one temple also nearby. Anyway, uh, I will carry that rice cooker. If I found that food I can get from the temple, that is okay. Very good. But if I don't get, then at least I can cook. So rice cooker I have to take with me. And for the transport, he's asking 2000. I think it is high. I think airport to yes, yes. I think uh, okay. These things I can manage over there also. No issues. It was an important thing to know about this cooking facility. Okay, then let just yeah, they have cooking facility, and he said there is one uh, temple also nearby. It is walking distance. I have seen in the Google map, and that temple. Actually, my plan was to before fixing any hotel or anything. I was planning to stay in any temple because temple stay is easy for me. Uh, uh, but uh, no need to think or worry about the food. But problem actually, see, people they don't keep their word. This is bad. So whenever you deal with anyone in a group or anything, it is better not to change the status. When this Omar and they told me 10 days before the exam they will be there and want to do all the examination and this everything want to do the practice. I said okay, and because of that, I booked my ticket. Now after that, so many events happen. You know those things regarding hotel booking. They kept me waiting for almost like 2 to 3 weeks. Because of that, the hotel price also increased. Like luckily, I got another one in a almost similar price. Regarding, but thing is, here also I have my room. Here I can stay, and just before 2 or 3 days of the exam, I can fly, isn't it? I no need to pay money in the hotel. I no need to pay for the food. Here I can. I'm managing from last almost 1 month. After stopping my hospital duty, they said last 10 days they want to do practice all the examination and this thing. Uh, so they want to be there. I said okay. And now Amar is his status is like that. Tomorrow he will go to uh, embassy and then he will check when he get the visa. Then only. And this another Dr. Samjana, she said she will go on 29th. So 29th and my exam is on 2nd. So what is the benefit of 29th? Nothing. On that time, I will not even prefer to discuss with them. So this is something they should not have done with me. I could stay here. This is my room, my environment. I have my own setup. But after going there, I hope it will be okay. I hope it will be helpful. Yes, maybe. Hmm. So good thing he confirmed that I can cook. Let's see. After going there, first I will try to go to the temple and I will talk with their. I tried to. Okay, because of them only. Because of these doctors. Otherwise, from the beginning, my plan was to contact with any temple and can stay there easily. They will keep me with pleasure. I mean, they will be also happy. I will be also happy. Uh, Tep- yes, yes, yes. Temple has rooms for the guest or the suppose a tourist or the devotee. They came from other countries. They used to stay. I will pay. They will not ask for money. I know. They will not ask for money. They will not ask for the money for the food even. They will give me free food, free accommodation. But from my side, I will give because they can use it for some temple purpose. And that temple is very, very old, more than 2000-year old temple. Very old. I mean, that good. That is good. Very. I mean, from the religious view, it is a holy place, uh, and it is a good temple. I have seen many pictures. Uh, so okay, tomorrow by this time I will be there. Yes, yes. Hmm. No, no, no. I will reach even by 2 hours before than this. 1 hour before. The time mentioned there, 16:10, 16:10, India local time. India local time. Now, check what is the India local time now. Local time. It will be, I think, now 17 or 18, almost like 18 now. 5:51 means 17:51. Yes, I'm in the hotel by this time. Okay, okay. Let's read little rapidly now. Yeah, I will repeat it rapidly. Hmm. This format is easy. And that's why I was trying to understand. If they ask me urobilin metabolism, here is bilirubin metabolism. And that question was how urobilin form and how it circulates. So if they ask from urobilinogen, then I will start from large gut. Small intestine, no need to talk. Yes. Just we will say the conjugated bilirubin is deconjugated by gut flora and it becomes urobilinogen. Then 50% of this urobilinogen is again oxidized by the bacteria to stercobilin. First from unconjugated bilirubin, sorry, they remains as like conjugated bilirubin in the small intestine, small intestine conjugated bilirubin. When they come into the large gut, then they become unconjugated. Deconjugated means unconjugated by gut flora. Once unconjugated, then again gut flora act on them and they do oxidation and then it becomes stercobilin. They go with the stool and remaining 50% reabsorbed in the circulation from the gut because gut what we have gut we have mesenteric vein, right? With that mesenteric vein it reabsorb 50% reabsorb and 50% already it is oxidized by the bacteria and it is going with the stool halas. Those 50% which remaining it is taking up by the blood by the circulation from the gut. Then it is entering into the from the mesenteric vein. It is going to the suppose superior mesenteric, then inferior mesenteric. Then ultimately it is going to the portal vein, entering into the liver. When into the liver again, they are uh, absorbed, reabsorbed, reabsorbed into enterohepatic circulation. When through the portal vein, when it is going into the liver, they are reabsorbed into enterohepatic circulation. And reabsorb means ultimately it is going into the systemic circulation, and from there it is going into the kidney because systemic circulation, how they can go to the kidney through the renal artery, right? And if they want to go through the renal artery, they must come through the abdominal aorta. That abdominal aorta to they will go to the renal artery. So abdominal aorta, how abdominal aorta will get from liver when they are again reabsorbed by sinusoids, then they will enter into the hepatic vein. Through the hepatic vein, they will enter into the inferior vena cava. Through inferior vena cava, it will go to the right atrium. From right atrium to right ventricle to liver, sorry, lung, lung to through pulmonary, no, lung to pulmonary, artery, they will pulmonary vein, they will come to left atrium, from left atrium to left ventricle, from left ventricle through arch of aorta, then they will descend to abdominal aorta, then they will go to the renal. Ultimately, this is systemic circulation. From portal circulation, it will come to systemic circulation, and part of it will go to the kidney through renal artery that will form urobilin. So, talk about bilirubin metabolism. In the small intestine, the conjugated bilirubin in the bile, okay, in the small, I will start little earlier. In the liver, the bilirubin is conjugated, and then they secrete through the bile and enter into the small intestine. Into small intestine, bile salt is reabsorbed to enterohepatic circulation, but but conjugated bilirubin is not absorbed. It enters into the large intestine, and in large intestine, by the bacterial flora, they are deconjugated and form urobilinogen. 50% of the urobilinogen is oxidized by the by the bacteria. That this unconjugation done by gut flora, and oxidation is done by bacteria. These two different. Okay, 50% is oxidized by the bacteria and produce stercobilin, which forms the brown color of the stool. And 50% of the urobilinogen again reabsorbed into systemic circulation. From there, part of it again reabsorbed into enterohepatic circulation, and part go to the kidney and convert to urobilin and forms the yellow color of the urine. Okay, I think this is enough. Prothrombin time and INR. Prothrombin time and INR. By giving injection vitamin K 10 milligram once a day for 3 days. Injection IV vitamin K 10 milligram once a day for 3 days. If we want rapid correction, after consulting with the hematologist, we can give fresh frozen plasma prothrombin complex concentrate. Vitamin K, vitamin K 10 milligram OD for 3 days. If we want a rapid correction, we can give fresh frozen plasma or prothrombin complex concentrate after discussing with the hematologist. What are the content in prothrombin complex concentrate? Factor 8, factor 13, and von Willebrand factor. Cryoprecipitate. Oh, that is in cryoprecipitate. Okay. Prothrombin complex concentrate directly in the blood product. Okay. Hmm. Okay. Reabsorption of the bile salt. Enterohepatic circulation means they are asking about the bile salt, not the bilirubin. Bile salt, bile salt. So reabsorption of the bile salt from the terminal ileum and return back to the liver, 95%. Uh, Reabsorption of the bile salt from the terminal ileum and return back to the liver is called enterohepatic circulation. More than 95% of the bile salt is reabsorbed again. And the remaining 5% that is actually supplied by the food source. So that's why healthy adult, they are maintaining their 100% circulation. Otherwise, every day if they lose 5%, then ultimately in 10 days their whole bile salt supply will be zero. You got my point. Hmm? Okay. What could be the cause of silent obstructive jaundice? Carcinoma of the head of the pancreas. What other investigation you would do if you find a severe stone in ultrasound, ERCP? If the patient have pain, fever, and jaundice, ascending cholangitis, this is called Charcot's triad. Management of ascending cholangitis. It is a critically ill surgical patient. I will manage the patient in ITU, and I will keep the patient on high flow oxygen, IV fluid, intravenous. Okay, high flow oxygen, IV fluid, and intravenous antibiotic, third or fourth generation of cephalosporin. So when ascending cholangitis, very specific, here directly we go to third or fourth generation cephalosporin. Remember from the beginning when we got esophageal varices, variceal bleeding, we directly started 2 to 4 liter of cross match and blood transfusion. Then we got perforated peptic ulcer. In that patient, we kept the patient NPO and prepared for the definitive management. That was omental repair by perforation repair by omental patch or gram patch. And here, ascending cholangitis, we are saying directly we are starting third or fourth generation cephalosporin with metronidazole, and we will send for blood culture, chest X-ray, and urine analysis, checks lactate and hemoglobin, and hourly urine output by urinary catheter. And then go for emergency biliary drainage. Emergency biliary drainage, how? Go for emergency biliary drainage because it is obstructive. So if we don't drain, it will collect it and it will cause more problem. So go for emergency biliary drainage. Definitive management by surgical removal of the stone by ERCP. Again, uh, I will manage the patient according to care of critically ill surgical patient. I will keep the patient in ITU, and I will keep the patient on high flow oxygen, IV fluid resuscitation, and intravenous antibiotic, third or fourth generation cephalosporin with metronidazole, and will send blood for blood culture, chest X-ray, urine analysis, and check for lactate and hemoglobin. Urine analysis, check for lactate and hemoglobin. To see the response, we'll put a urinary catheter and take hourly, and we'll prepare the patient for definitive management. That will be surgical removal of the stone by ERCP. What antibiotic? Fourth generation cephalosporin with metronidazole. Could we use endoscope? No, because the opening endoscope is enteroscope and ERCP is a sidoscope. So we cannot cannulate the CBD. Explain why blood clotting rearrange the liver synthesis most of the clotting factor in biliary obstruction. These will be decreased. In biliary obstruction, there will be decreased absorption of vitamin K. In biliary obstruction, there will be decreased absorption of vitamin K, which is required for the synthesis of 27,9,10. Vitamin, yes, vitamin K dependent vitamin. Vitamin. It is vitamin. Vitamin will be more vitamin if you say vitamin. But if you say vitamin, it is light. Okay. Explain how it sounds like it is light. It is like water. It is not vitamin. When vitamin, yes, it will give you strength and energy and everything. It will boost your immune system. But when it is vitamin, it is like water coming and going. Okay. Okay. Hmm. 45-year-old diagnosed and managed for acute pancreatitis 2 weeks ago. So it will be pancreatic cirrhosis or what? Managed, diagnosed and managed for acute pancreatitis 2 weeks ago. Now presented with vomiting, shortness of breath, and epigastric pain, which is not improved with PPI. Examination revealed tachycardia and tachypnea. Yes. Which enzyme? Mhm. Lactate dehydrogenase. amylase and lipase valuable, and is lipase is more specific than amylase, because amylase is not specific and can be normal if measured too early or too late because of its short half-life. Lipase we will do lactate dehydrogenase, apart from this lactate LDH, okay, lactate dehydrogenase, and lipase are more specific than specific to the pancreas. Amylase is not specific because it can be normal if we measure it too early or too late because of its short half-life, which is 48 hours only. What are the causes of post-cholecystectomy? Pancreatitis, hydrogenic injury, retained stone, infection, and stricture. Hydrogenic injury to hepatobiliary system, pancreatic system, okay. Then infection, retained stone in CBD, and stricture. Patient came with jaundice and ascending cholangitis 6 months after surgery. Reason, retained stone causing obstruction and stricture. Written stone causing obstruction and stricture. 5 weeks after the initial attack, patient presented with epigastric fullness, vomiting, and dyspepsia, and diagnosis is pancreatic cirrhosis. Define cirrhosis and what does it contain? It is a collection of amylase-rich fluid enclosed in a wall of fibrous or granulation tissue. It is a collection of the amylase-rich collection of amylase-rich fluid enclosed in a wall of fibrous or granulation tissue. Collection of amylase-rich fluid enclosed in a wall of fibrous or granulation tissue. Difference between cancer and cirrhosis. In in cancer, in cancer, fluid viscosity will be high, and cirrhosis fluid viscosity will be low. In cancer, tumor marker will be high. In cirrhosis, tumor marker will be low. And amylase will be high in uh, cirrhosis, but will be low in cancer. Fluid viscosity, tumor marker, and amylase. Also CT finding. Four things. One is fluid viscosity, tumor marker CA 19-9, and amylase and CT finding. Difference between cancer and cirrhosis. Okay. In cirrhosis, fluid viscosity will be high in cancer, but less in cirrhosis. Tumor marker CA 19-9 will be high in cancer, but low in cirrhosis. Amylase will be high in cirrhosis and low in tumor and CT finding. What is the difference between true cyst and cirrhosis? Pseudocyst is not closed and does not have a lining epithelial cell. Pseudocyst is not closed and does not have a lining epithelial cell separating it from the nearby tissue. Instead, its wall is made up of fibrous and granulation tissue. Cyst is a collection of fluid, which is correct. Cyst is collection of fluid surrounded by a fibrous tissue. But a pseudocyst is made up of no epithelial. Sorry, cyst is by epithelial tissue. Pseudocyst is not closed and does not have any lining epithelium. Yes, cyst will have a lining epithelium like sebaceous cyst, other cyst, ovarian cyst. So cyst will be enclosed by a lining epithelium, but pancreatic cyst or pseudocyst is not covered by a lining epithelial, and it will be covered made up of a fibrous or granulation tissue, separating it from the nearby tissue, and instead its wall is made up of fibrous or granulation tissue. Okay, this is enough if we say like this. Cyst is covered by epithelial tissue, but pseudocyst is not covered by any epithelial tissue. Rather, it is covered by a fibrous or granulation tissue. Fibrous or granulation tissue. Hmm. Okay. Huh? Hmm? Read, read, read. Key, key. key, Ki, key, Ki is key, or Ke. No, key means what? Key, not that key. That is okay. Pronunciation will be same. Key, key. Yes, that is more accurate. If you say key means what, and what happened? If you want to say what happened, key hoise, 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 hoise. Yes, hoise. Yes. Very nice. কি হইছে অথবা কি হইছে হইছে Hoise হইছে হইছে হুম কি হইছে yes you can talk with my mother like this কি হইছে she will she will start talking eh 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 okay. In case of pancreatic, okay, what is the difference between cyst and cirrhosis done? In case of pancreatic necrosis, what investigation of choice? CT abdomen with IB contrast and pancreatic protocol. CT abdomen with IB contrast, pancreatic protocol. What is the finding to look for in the CT? Fat standing, edema, and collection. I remember it in another way. Okay. Fat stranding, what we will look for? Okay, we look for any abscess, collection, pseudocyst, necrosis. What we will look for? We will look for any abscess, any collection, pseudocyst, fat stranding, edema, fat stranding, edema, collection, pseudocyst, abscess, necrosis. What we will look for? We will look for uh, abscess, collection, necrosis, edema, fat stranding, edema, collection, cirrhosis, abscess, necrosis. Okay. What is the biochemical finding? We are reading now pancreatic pseudocyst. Pancreatic pseudocyst. 1 month before there was pancreatitis. Now he came with pancreatic pseudocyst. Pancreatic pseudocyst. So what he will have? Only sugar will increase and everything will decrease. Pancreatitis, yes. In pancreatitis, sugar increases, other everything decreases. So because yes, insulin started, insulin does not work. So sugar will increase, other things will reduce. So hyperglycemia, hypocalcemia, hypomagnesemia, hyperalbuminemia, hypocalcemia, hypomagnesemia, hypoalbuminemia. Why the calcium is low in early stage, late stage. In early stage, autodigestion of the mesenteric fat, autodigestion of the mesenteric fat by pancreatic. This is hypocalcemia. Why hypocalcemia? Hypocalcemia, hypomagnesemia, hypoalbuminemia. Why hypocalcemia? In early stage, autodigestion of the mesenteric fat by the pancreatic enzyme and release of free fatty acid, which form calcium salt. Autodigestion of the mesenteric fat by pancreatic enzyme. Autodigestion of the mesenteric fat, autodigestion of the mesenteric fat by pancreatic enzyme and release of free fatty acid, which form the calcium salt. Okay, autodigestion of the mesenteric fat by autodigestion of the mesenteric fat by pancreatic enzyme and release of free fatty acid. Release of fatty acid, which form the calcium salt, causes saponification of fat, so it reduces the calcium again. Autodigestion of the mesenteric fat by pancreatic enzyme and release of free fatty acid, which bind with the calcium and causes saponification of the fat. So circulating calcium decreases. And in late stage, due to complication because of the sepsis and hypoalbuminemia and transient hypoparathyroidism. In late in the late stage because of the complication like sepsis, hypoalbuminia, and transient hypoparathyroidism. Okay, so in early stage and late stage, this one and late stage due to complication, sepsis, hypoalbuminia, transient hypoparathyroidism. Why is there hyperglycemia? Destruction of the beta cell of the islets of Langerhans that normally secrete insulin, and also could be due to stress response because of cortisol and catecholamine. Due to stress and destruction of the beta cell by of the islets of Langerhans that normally secrete insulin, also uh, could be due to stress response, cortisol and catecholamine increases. Hmm. How would you classify obstructive jaundice according to the cause? Intraluminal, intra, no, 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 interluminal and extraluminal. Extraluminal, transluminal, and intraluminal. Extraluminal. Okay, okay, okay. Starting from the intraluminal, transluminal, transluminal, and extraluminal. Intraluminal because of the stone, transluminal cholangiocarcinoma, and extraluminal cancer in the head of the pancreas. Intraluminal because of the stone, transluminal cholangiocarcinoma, and extraluminal cancer of the head of the pancreas. Cancer in the head of the pancreas. Cancer in the head of the pancreas. Mm. Interluminal, and extraluminal. Okay. What could be the cause of silent obstructive carcinoma at the head of the pancreas? How could you manage a patient with acute pancreatitis? This station we have in many places: pathology, critical care. Uh, okay. So, pancreatitis. By CRISP protocol using ABCDE approach, admit the patient in ICU or SDU, analgesia, uh, aggressive fluid rehydration, supplemental oxidation, close monitoring, uh, central venous pressure, urine output, blood glucose, frequent monitoring of liver function test, renal function test, clotting profile, serum calcium, blood glucose, nasogastric drainage, antibiotic if suspected cholangitis, nasogastric drain only. No, here we'll say that after diet layers with the dietitian, and preferably enteral. If severe case, then parenteral, total parenteral. Then antibiotic if suspected for cholangitis, no, antibiotic after discussing with the microbiologist and checking hospital policy. And octreotide and PPI, octreotide decrease pancreatic secretion, PPI prevent stress ulcer, CT scan if organ failure, CT scan if organ failure and clinical deterioration and sign of sepsis, ERCP within 72 hours for severe gallstone pancreatitis and sign of cholangitis. Supportive therapy for organ failure if develop inotrope, ventilatory support, and um, uh, hemofiltration. If nutritional support required, nasovaginal tube. Okay, okay. Um, does steroid have a role in the pancreatitis? Yes. Corticosteroid suppress the release of inflammatory cytokines. Corticosteroid suppress the release of inflammatory cytokines, leading to reducing hospital stay and need for surgical intervention and the mortality rate. Corticosteroid suppress the release of inflammatory cytokines. Corticosteroids suppress the release of inflammatory cytokines, which leading to decreased length of hospital stay and need for the surgical intervention, reduce the need for surgical intervention, and decrease the mortality. Management of the nutrition, enteral feeding with a nasovaginal tube in severe pancreatitis. total parenteral nutrition. What scoring of pancreatitis? You know, Glasgow criteria, Ranson criteria, Apache 2, Glasgow criteria, Ranson's criteria, Glasgow criteria, Ranson's criteria, Belt Hazard and Apache 2, Glasgow criteria, Ranson criteria, Belt Hazard and Apache 2, Glasgow, Ranson, Belt Hazard, Apache 2. Talk about one of each. 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 Okay. Glasgow criteria: pancreas. Partial pressure of oxygen less than 8 kilo Pascal. Normally 10 to 13. Okay. They will not ask about the normal. Just okay. Partial pressure of oxygen less than 8 kilo Pascal. Age more than 55. Neutrophil count more than 15,000. Calcium level less than 2 millimole after 48 hours. Calcium here, calcium, then what else? Calcium and CEA. Calcium, E and A for albumin. CEA after 48 hours. Calcium enzyme and albumin. Calcium enzyme, which one? Lactate dehydrogenase. Lactate dehydrogenase means initially we will do once and again we will do after 48 hours again. And in the criteria, we will calculate this value. Initially, we will do to check either this patient have any electrolyte imbalance. Suppose if patient is in severe hypokalemia or hypercalcemia, we need to manage. We should not wait for 2 hours. No, no. To do the Glasgow criteria, we have to do it after 2 hours. But what will happen in the 2 days? If patient die from hypercalcemia, then to complete our Glasgow criteria, we can complete, but patient also will complete his stay in the earth. So it does not mean that we will do it after 48 hours. We will do in the beginning all, but we will repeat it after 48 hours again, and that level will be calculated for the criteria. Okay. Again, pancreas, PANCREAS. Partial pressure of oxygen less than 8 kilopascal, age more than 55 year, neutrophil count more than 15,000, calcium less than 2 millimole after 48 hours, renal function in urea more than 16 millimole per urea level more than 16 millimole per liter. Enzyme lactate dehydrogenase more than 600 after 48 hours. Lactate dehydrogenase more than 600 after 48 hours. Albumin less than albumin less than 32 gram per deciliter after 48 hours. Albumin less than 32 gram per deciliter after 48 hours. And PNCREAS, S for sugar, sugar level, glucose level more than 10 millimole per liter. At least three of the above indicates severe sepsis. At least three of the above. At least three of the above severe episode, and patient need ITU admission. At least three of the above. At least three of the above indicates severe. At least three of the above indicate severe episode, and patient need ITU admission. Calcium is lactate dehydrogenase and albumin we do after 48 hours, where calcium level is less than 2 millimole per liter, lactate dehydrogenase more than 600 after 48 hours, and albumin less than 32 milligram per deciliter, gram per deciliter. What are the early and delayed complication of acute pancreatitis? Early complication of acute pancreatitis. Acute pancreatitis, necrosis, acute respiratory distress syndrome, pleural effusion, and electrolyte disturbance. That is hyperglycemia, hypocalcemia, hypomagnesemia, hypophosphatemia. Necrosis. Pancreatitis may cause necrosis and acute respiratory distress syndrome, pleural effusion, and electrolyte imbalance, hyperglycemia, hypocalcemia, hypomagnesemia, hypoalbuminemia, and late complication, pancreatic cirrhosis and splenic vein thrombosis. Pancreatic cirrhosis, splenic vein thrombosis. How to manage splenic vein thrombosis? Splenic vein thrombosis we can manage by multidisciplinary approach. Multidisciplinary approach including splenic vein thrombosis. Okay. patient with a hemorrhagic pseudosis, multidisciplinary approach including gastroenterologist or hepatologist, and gastroenterologist or hepatologist and hematologist, and interventional radiology for radiological intervention if require coiling, interventional radiology. So gastroenterologist, hematologist, and interventional radiology. If required, then go for interventional coiling. Complication of the coiling, injury to the surrounding structure, injury to the surrounding structure. Why coiling here? Because of hemorrhagic pseudosis. Hemorrhagic pseudosis. If it is not hemorrhagic, then no need to do anything. If it is hemorrhagic, splenic vein thrombosis. Okay, splenic vein thrombosis. So splenic vein thrombosis also we need to take care, and hemorrhage. So for that we have to approach a multidisciplinary team, gastroenterologist or hepatologist with hematologist and interventional radiologist. Okay. For okay, complication of the coiling, injury to the surrounding structure, hemorrhage, and failure to stop bleeding. Right. This failure means failure to stop bleeding and infection. Injury to the surrounding structure, hematoma formation, or hemorrhage. Injury to the surrounding structure, hemorrhage and hematoma formation, infection, failure to stop bleeding. Management of the pain. According to WHO anesthesia ladder, but I will try. Okay, Start with non-opioid like paracetamol. According to WHO step leader, start with non-opioid like paracetamol, then weak. First non-opioid paracetamol, weak opioid codeine, and then weak opioid like codeine, then strong opioid like pethidine. And the best is patient control analgesia, and epidural. So I will manage according to WHO NSA step ladder pattern. First, we'll start with non-opioid like paracetamol, then weak opioid like codeine, then strong opioid like strong pethidine, and then the best is patient control analgesia or epidural analgesia. Why not morphine? Because it causes the constriction of the sphincter of AD. It is only the theoretical. CRP is a C-reactive protein, which is released from the hepatocyte in response to acute inflammation. It is not disease specific, but it gives the idea about the disease prognosis. Case of causes of tachypnea in this patient. Tachypnea. Okay. He's breathing fast. Tachypnea. Why? Because of acute respiratory distress syndrome and sympathetic overactivation and compression OAS. This is good reason. Compression of the diaphragm by pseudocyst. So to complete his oxygen demand, he has to take repeated or more breath, like in hypovolemia, heartbeat more to meet the demand. The same compression of the diaphragm by pseudocyst, sympathetic overactivation, and sympathetic overactivation. Acute respiratory distress syndrome. You're syllabing. Hmm? You're syllabing. Again. Okay. Input. Hmm? Okay. diverticular abscess and septic shock. Patient after anterior resection of the POD. Can I get 10 minutes? Not 10 minutes, 5 minutes. A short break. Uh, okay. Okay. I will write the application for the consideration. Okay. Patient after anterior resection, postoperative day 4, respiratory rate 28 per minute, BP 80-50, pulse 110, temperature high, urine output less. What is the diagnosis? Patient is in septic shock. Differential diagnosis, anastomotic leak, sepsis, and anastomotic leak, peritonitis, infection. Anastomotic leak, peritonitis, and infection. Anastomotic leak, peritonitis, and infection. Anastomotic leak, peritonitis, anastomotic leak, peritonitis, and infection. Anastomotic leak, peritonitis, and infection. Quick sofa, quick sofa, quick sofa, quick sofa, quick sofa, quick sofa. Last night also we studied quick sofa. It is a scoring system which gives the idea about the mortality of a hospitalized patient or the outcome of a ICU patient. It has three criteria and it has 3 points. The criteria are systolic blood pressure less than 100 millimeter of mercury, respiratory rate 22 breaths per minute or more, and Glasgow Coma score less than 15. There was altered mental status, but here they gave Glasgow Coma score. Remember? Last night when we studied pathology, it was written altered matter. Here they give same thing. Systolic blood pressure less than 100 millimeter of mercury, respiratory rate 22 breaths per minute, and Glasgow Coma score less than 15 or altered mental status. In interpretation 0 to 1 point indicates no, not high risk. 0 to 1, not high risk. 2 to 3, high risk and poor outcome. Causes of acute kidney injury: pre-renal, renal, and post-renal. Pre-renal dehydration, diuretics, DBD, dehydration, vomiting, diuretics. Also sepsis, dehydration, hypovolemia, and the hemorrhagic shock. Okay. Pre-renal, sepsis, dehydration, hypovolemia, secondary to hemorrhage. For this patient, what happened? This is a POD4 and this is anterior resection. POD4 suspected that patient developed anastomotic leak and peritonitis and sepsis. Now, so renal failure. Why renal failure? It could be sepsis, dehydration, hypovolemia, secondary to hemorrhage. Okay, and renal cause glomerulonephritis, drugs, nephrotoxic drugs like NSAIDs, ACE inhibitor, aminoglycosides. Glomerulonephritis, NSAIDs, ACE inhibitor, aminoglycoside, and post-renal ureteric stone, or benign prostatic hyperplasia. What are the investigation you would order? This patient, okay, first I will rule out the inflammatory marker by CBC, high WCBC, and then inflammatory marker CRP and ESR also will be high. Then to rule out the metabolic disorder, I will do ABG and lactate dehydrogenase, blood culture, urea, and electrolyte. Um, then we will do for imaging. Just think practically. This patient came this and that. What we will do in our ward? We will do CBC, CRP, urea electrolyte, creatinine, serum blood glucose level, lactate dehydrogenase, um, electrolytes, and blood culture and urine culture, and then we will do for abdominal ultrasound because we need to know what is happening, abdominal X-ray, abdominal CT, and then according to the diagnosis we will proceed for the management. We are suspecting this is an anastomotic leak and patient is now in sepsis. So first, this is a critically ill surgical patient. I will manage by CRISP protocol. I will admit the patient in ITU, will give high flow oxygen, IV antibiotic, and IV fluid because I'm suspecting this is an anastomotic leak. High flow oxygen because he is tachypneic. High flow oxygen, IV fluid, and IV antibiotic. Then take blood for culture and baseline investigation. Culture, lactate dehydrogenase, hemoglobin level, chest X-ray, urine analysis. And to monitor response, insert a urinary catheter and hourly monitor urine output. Then renal support by dopamine or furosemide. Renal support, dopamine or furosemide. This will be difficult to remember like this. Renal support. In general, CRISP protocol. If renal function is compromised, we will give renal support by dopamine or furosemide. Dopamine or furosemide. To both are opposite side. Furosemide we use in case of high fluid overload, and dopamine we use when there is circulatory failure instead of normovolemia. I mean, there is no. Mhm, hmm, hmm. Then dopamine or furosemide. Then nutritional support by, okay, this is good in shortcut and smart way. Renal support either by dopamine or furosemide. And fluid, no. Nutritional support, maybe enteral is preferred over parenteral. Then treat the underlying cause. Okay. Okay, so what we'll do, anastomotic leak patient. Okay, first we'll inform my consultant and inform ITU registrar. We'll admit the patient in ITU. We'll start the patient with high flow oxygen, IV fluid resuscitation, and um, IV intravenous antibiotic after discussing with the microbiologist and checking hospital policy. Then we'll send blood for baseline investigation, including lactate dehydrogenase (ABG) and hemoglobin level, and serial hemoglobin, serial lactate and hemoglobin, and urine analysis for also culture and sensitivity, and to check response, urinary catheter, and hourly monitor the urine output. Then for the renal support, either dopamine or furosemide, and nutritional support, enteral or parenteral, and then the definitive treat the underlying cause. How will check the response of the treatment? Monitoring vital signs, pulse, baby temperature, urine output, capillary refill time, and temperature. Monitoring the urine output, hourly monitoring mental status. Give the following ABG diagnosis: pH 7.1 acidosis and bicarbonate low, so it is metabolic acidosis. Metabolic acidosis uncompensated. Uncompensated because carbon dioxide level is still normal. Metabolic acidosis uncompensated. Why metabolic acidosis? Because of the sepsis, which leads to accumulation of the lactate. Lactate, which occurs in MI also. Remember, after stopping aerobic glycolysis, anaerobic glycolysis starts, and there will be formation of the toxic metabolites, and this lactate is accumulated into the myocardium, and there will be some changes, ultrastructural changes. So this lactate happens everywhere where there is any sepsis or lack of oxygen supply. Metabolic acidosis. Because of the sepsis leads to accumulation of the lactate, and this lactate causes lactic acidosis, and acidosis is acidosis, metabolic acidosis. Defined shock. Shock is a circulatory failure resulting in inadequate shock is a circulatory failure resulting in inadequate organ perfusion which cannot meet the metabolic demand of the body. Shock is a circulatory failure resulting in shock is a circulatory failure resulting in inadequate organ perfusion. Shock is a circulatory failure resulting in inadequate organ perfusion that cannot meet the metabolic demand of the body. Different how to differentiate septic shock and hemorrhagic shock. In septic shock, there will be peripheral vasodilation, and the periphery will remain warm, but patient will be tachycardic. And in hemorrhagic shock, peripheral vasoconstriction, periphery will be cold, and patient will have tachycardia. Bloody diarrhea. 55. Uh, 55-year-old male patient with abdominal pain, 55 male patient abdominal pain and bloody diarrhea, vitals BP 90-60, pulse high, temperature high after admission and had abdominal episode of bloody diarrhea, which stopped 6 hours later after admission. After admission had additional episode of bloody diarrhea, which stopped 6 hours later. Initial resuscitation done with IV fluid. Lab result hemoglobin 8.8, platelet 6,66,000, WBC 12,000, sodium low, potassium low, CRP high, creatinine and urea. Bloody diarrhea after admission, again blood and then stop. Hmm. What can you see in the blood picture? There is thrombocytosis, hmm. low hemoglobin, Okay, there is anemia, and leukocytosis. There is a anemia, leukocytosis, thrombocytosis, and electrolyte imbalance like hyponatremia, hypokalemia, and impaired renal function, high urea and creatinine, and high CRP. Low hemoglobin, we will say instead of low hemoglobin, we will say anemia. High level of WBC, we will say leukocytosis. High level of platelet, we will say thrombocytosis. Low sodium potassium will say electrolyte imbalance, hyponatremia, hypokalemia, and high CRP, or then urea and creatinine will say impaired renal function. What are the type of anemia in this case? Microcytic hypochromic anemia, microcytic hypochromic anemia, microcytic hypochromic anemia. What are the type of anemia? What are the type of anemia here? Microcytic hypochromic anemia, microcytic hypochromic anemia, microcytic hypochromic anemia, microcytic hypochromic anemia. What's your more uh, what is your comment on the platelet count elevated? You can ask the question. One is secondary to acute inflammation because platelet is a acute phase reactant. Secondary to acute inflammation and dehydration. CRP, ferritin, and procalcitonin. CRP, ferritin, and procalcitonin. CRP, ferritin, procalcitonin. Uh, Abnormal dilatation of the ascending colon, transverse colon, and narrowing of the descending colon. Also, thumb print sign. Dilatation of the ascending colon, transverse colon, and narrowing of the descending colon and thumbprint sign, which suggestive of colitis. Thumb printing sign is cholangitis. Sorry, colitis, colitis. Yeah. Inflammatory bowel disease. Mhm. Common causes of bloody diarrhea, inflammatory bowel disease like ulcerative colitis, Crohn's disease, and infections, amoebic colitis, bacillary dysentery, amoebic colitis, bacillary dysentery, infectious colitis, infectious colitis, amoebic colitis, bacillary dysentery, infectious colitis by Clostridium difficile, Campylobacter jejuni, and ischemic colitis, carcinoma colon, and diverticular disease in the left colon. Diverticular disease in the left colon. No need to say this thing, right or left. Again, inflammatory bowel disease, ulcerative colitis, Crohn's disease, then infectious like amoebic dysentery, amoebic colitis, bacillary dysentery, then infectious colitis by Campylobacter jejuni, Clostridium difficile, and ischemic colitis, carcinoma of the colon, and diverticulitis or diverticular disease. In the view of the blood, loss, and hypotension. Would you give this patient blood and why? No, because the patient is in the state of sepsis and not indicated as the hemoglobin is not below, not indicated, the hemoglobin level is not an indication for the blood transfusion. The state of sepsis and the hemoglobin level is not the indication of the blood transfusion for this acute case. Because in acute case it is now hemoglobin is 8.8, and indication of blood transfusion for chronic blood loss is less than 7, and in acute indication of transfusion when less than 9. Hyponatremia and hypokalemia because of the diarrhea, loss from the diarrhea. Mm-hmm. I will request for ESR procalcitonin, which is the early marker of the sepsis, stool analysis and culture. Mainly, this is ulcerative colitis, right? Ulcerative colitis. So we are now doing ANCA, PNCA, fecal calprotectin, CEA, and ultimately colonoscopy. So first we will do inflammatory markers like CRP. Already this is done. Okay, already this is done, and now ESR and procalcitonin. ESR and procalcitonin, stool analysis and culture. ESR and procalcitonin, stool analysis and culture. Then antibodies for ulcerative colitis, that is ANCA, EANCA, and fecal calprotectin, carcinomembranous antigen. ESR procalcitonin, fecal calprotectin. Altogether, you can say ESR, fecal calprotectin, procalcitonin. Um, Stool analysis for culture, and antibody for ulcerative colitis and Crohn's, antibody for ulcerative colitis and Crohn's, ANCA, PANCA, and carcinomembranous antigen. And when the acute attack subsides, we can go for colonoscopy. ESR, procalcitonin, fecal calprotectin, stool analysis and culture, antibiotic for ulcerative colitis and Crohn's disease, ANCA, PANCA, with the okay, carcinomembranous antigen. And once the patient is vitally stable, we can ring, we can uh, হুম, না, কি হয়েছে, কি হয়েছে, হুম, কিচ্ছু হয় নাই, নাথিং হ্যাপেন্ড, কিছু হয় নাই, নাই, নাই মিন্স নো, হুম, কিছু হয় নাই, কিছু, কিছু মিন্স সামথিং or anything, কিছু, কিছু হয় নাই, nothing happened. So you learned কি হয়েছে, what happened, then answer, nothing happened, কিছু হয় নাই. With us, we had Nepali doctors. I mean, Nepali students in our medical college. They learned our language in 6 months, very rapidly, and some in 6 months. Yes, they learned. Those who wanted to learn, some they didn't. They were not interested. They didn't learn, and some were really interested. Most of them really interested, and they learned. Some of them even learned writing, because in internship we have to write the discharge summary. That time it was handwritten, not printed. So they used to write in the hand and Bengali alphabet. Very nice. I know, remember his name. His name was Subhas, Amit Subhas. Hmm. Okay. Subhash. I remember this name because this name is my family name. My father's name also Subhash. Subhash Adhikary. What is his name? What is his name? Devi is mother. Hmm. Yeah. So her name, she will get something from mother's name. Suppose Adhikari is our family name, and Devi is part from mother's name because mother's name is Riva uh, Devi or Riva Rani usually. Devi actually it comes specifically for the name. Her name is Monica or Mamuni, Monica Devi Adhikari. My mother's name is Riva Rani Adhikari. Father is Subhash Chandra Adhikari. And me, Sudhanshu Adhikari. Okay, we will do ESR, procalcitonin, and fecal calprotectin, stool analysis, and culture antibodies for ANCA and PNCA. Fecal antibodies for ulcerative colitis and Crohn's disease, ANCA, PNCA, and carcinomembranous antigen and colonoscopy. No imaging with contrast because DRN renal function test. How could you know this patient is improving? Clinically, fever subside, fever settles and diarrhea stops. I like this answer. Clinically, fever settles and diarrhea stops, and lab shows decreased CRP and decreased TLC. How can you know the patient is improving? Uh, some station the same question, but they answer only the clinically by monitoring his pulse, BP, temperature, these things. No, this answer is more nice. Clinically, if fever settles and diarrhea stops, and lab shows CRP decrease and total leukocyte count or WBC count reduce. This is the practical what we see in the ward and the hospital because we don't bother much about this. What was the blood pressure? What was the temperature, respiratory rate? No, we directly ask, sister, what is the WBC count and repeat count. What is the diarrhea? How many times he passed? We ask the patient. Patient say no, diarrhea stopped, no fever also. So clinically he improved. Fever settles and diarrhea stops. And lab shows his CRP reduced, total count reduced. So patient is improving. In the case if the cause of diarrhea is IBD, when surgical intervention would be an option if develop the complication like toxic megacolon refractory to medication and uncontrolled colonic bleeding. Yes. Toxic megacolon refractory to medical management, uncontrolled colonic bleeding, and obstruction. Okay, uncontrolled colonic bleeding, other complication like toxic megacolon, then perforation, obstruction with suspicious of, and colon cancer. Okay, what is the procedure of choice if it is emergency? Then in acute situation, we will do subtotal colectomy. In acute situation, we will do subtotal colectomy with ileostomy. Subtotal colectomy with ileostomy. In acute situation, subtotal colectomy with ileostomy. In elective situation, we will do pan-proctocolectomy with ileostomy. Pan-proctocolectomy with ileostomy. Um, I don't know why my video is not working. Yeah, in the start it was working, but now it is not working. Okay, it is okay, no problem, no problem. What I want to do, your video is not working. You see, it is written there. We couldn't access your camera. No, no, my video. Your video is working perfectly. Uh, I'm using my both monitor. So what I will do, I'll make little change.